purpose of our panel today is to explore health information exchanges and their implications in meaningful use. Before we get started, I'd like to thank our sponsors for today's panel, Dean Smith Partners, and also HIT Exchange. Without their support, this wouldn't be possible. My name is Todd Federling, Chairman and founder of Stratasan, a health analytics company located here in Nashville, Tennessee. And what I'd like to do next is just have each of the panelists quickly introduce themselves, and then we'll get into the first question.
Hi, I'm Rodney Hamilton. I'm the Chief Medical Information Officer and the Managing Director of the Product Strategy Practice for PointClear Solutions. We're a healthcare software development company that's focused on the intersection between the innovations in the healthcare delivery space and the development of technology to leverage those innovations.
My name is Jerry Malone. I'm Vice President for Sandlot Solutions based in Fort Worth, Texas. The primary focus of our organization is the analytics that are required by physicians for quality and meaningful use, and based on the HIE that we provide to our physicians.
My name is Brian Young, Director of Product Management for Shared Health Incorporated. Shared Health is in Chattanooga, based out of Chattanooga, Tennessee. Since 2004, we've been helping our customers exchange data, and most importantly, though, take that information, turn that data into insights, so we can deliver solutions to the point of care that help the providers provide the right information at the right time.
And I am Kim Lewis with HCA, which is a national provider of care. So I'll be representing the provider side of things. And our big focus, obviously, in this last year has been focusing on becoming more of a premier clinical company. And obviously, meaningful use has been key to our strategies in achieving that. And can say that we were proud to be one of only like 14% of hospitals that were able to hit stage 1 meaningful use. So I'll be representing the provider side today.
Thank you. In looking at where health information exchanges cross over into meaningful use, Kim in particular, I'm interested to understand where mission plays a role in here. How far off is this from your current mission and what you've been focused on versus how well does it meet your mission?
Fortunately, it ties right in line. Our mission, and when you look at what our number one objective for our company at the very top leadership level is to establish ourselves as a premier clinical company. For years, HCA has been doing very well in the financial area. For the last decade, we really wanted to focus on the clinical side. So with the meaningful use objectives that we've been able to meet, it aligned our clinical mission up and made it front and center. It helped us to optimize our current clinical systems that we have. It helped us to identify gaps that we have and also could see where our strengths lie. And so it definitely helped us to continue where we were already headed, which is in the clinical system arena and for being a premier clinical system provider. So.
Okay. And Jerry, I don't know if you could explain a little bit to follow on that, the physician practice and their mission to deliver care. Do physicians today see both health information exchanges and meaningful use as contributing to the overall quality that they can eventually provide?
Oh, absolutely. The health information exchange was put in place primarily 5 years ago to provide just that better patient care. Also to help manage costs and to optimize the efficiencies between a number of practices. And many of the practices, as we know, are not going to have the same EMR systems that could easily share information. So that sharing of information. And that's the whole point of meaningful use, is to bring that quality of care to the patients at a much lower price. And that's the primary focus of what our physicians are putting in place. We've looked at meaningful use from stage 1, but also stage 2 and stage 3 as we are surmising what that will be and how we can efficiently manage that. Texas Health Resources just recently, through their use of the HIE and other of their HIT applications, were able to get $16 million for meaningful use. So that was a very, very beneficial thing for our community to have that much money pumped for meaningful use into the environment.
Okay. I was reading just this morning a new report out from HHS that says that about 80% of U.S. hospitals are going to participate in the incentive program, but only about 63% are participating in stage 1. On the physician side, it's 40 and 35%. So interesting numbers. So maybe from a shared health perspective, you could tell us where are some early wins, and maybe if you have a story or two that you've seen either from the meaningful use and or how that's translated over into the health information exchange.
Well, I think, we've been around since 2004, and thankfully we've got a fantastic staff on our analytics team, which is led by Dr. Bruce Tappel, our Chief Medical Officer. One of the things that's been important for the company since its inception was to be able to collect data, metrics, and analyze how we're performing and how our patient populations are performing for our customers, to be able to demonstrate ROI to them. And even before meaningful use came about, we've been doing this work. And we found through multiple studies that we've done that we can quickly affect improvements in evidence-based medicine. We've seen upwards of a 15% improvement in colon cancer screening for users of our system. The system not only exchanges data, but again runs different clinical analytics and business intelligence against that data to alert physicians when certain interventions may be necessary. So, like I said, we've seen colon cancer screening rates improved by 15%, pneumovax improved by 35%. So there are, if you pick the right vendor and that you're looking to improve the overall health of the population of the community, if the vendor has tools that can allow the physician to identify those patients that are in need quickly, you can quickly affect change.
Todd, I'd like to add a little bit to that. From our HCA side, we employ many physicians, and obviously we have many, many affiliated physicians. And so when we were approaching meaningful use, we also wanted to very much consider the physician side of the house. And what we thought we would do at first would really help them select EMR. But once we got out into the individual practices and in front of our medical staff groups, there was such an education need just at the very base foundational level that they may have thought they already had an EMR, but in fact it was really just a billing system. So we end up changing our strategy into one more of just educating the physician on what meaningful use was. And there were several instances just by explaining to them what was in it for them from the stimulus side, we were able to pick up some dollars right on the table for them that they didn't even know, and they would not have known if we've not had some opportunities to educate them on making sure that the EMR that they had in place was in fact a true EMR, and then also that it was certified, or what the opportunity was to certify it, because many of them were homegrown by their sons in the garage, that they realized that that's not exactly going to get them there to meaningful use.
And are you using research evidence like the CLOS ratings and other things to help them better understand? You are going to have to make an investment, because I know you've probably got one of every flavor of physician practice management system. So is that helpful to them to understand, these are the 3 or 4 that have already been certified and this is where you need to be looking?
It is helpful, and one thing we've had to learn too as a company, that we were going down one trail for our own practices and selected one vendor for that, but then we realized in the EMR space one vendor does not fit all, and it's very specialty related, that one vendor may do a great job in cardiology but a pretty poor job in orthopedics. So we've had to get very specialized in how we looked at recommendations for our physicians based on what their practice is. Right. So it's been a lot of learnings for us from a provider side on what will make the physician's practice run more efficiently and what best fits their type of practice.
Okay. And Rodney, maybe you could tell us some stories of ROI-specific requirements that clients have had and are beginning to develop, both around meaningful use, but as we move from meaningful use now more rapidly into the health information exchange.
I don't really have anything to quote, particular statistics. I think the jury's out still for a lot of implementations, because frankly people are just starting to grapple with sort of the move from an analog world to a digital world, and I think the focus of many practices today is just exactly that. I mean, it's getting data in the system to where they can do something with it. So I mean, I think, certainly there are large groups, there's hospital systems that have published things that, reflecting ROI in various different capacities. Honestly, I think if you had some sophisticated financial people look at some of this, you'd probably poke some holes through a number of things that have been published today. But I think that's because we're predominantly very early in one capacity. And the other side of that is I think we didn't do a great job of measuring before. So everything was at a very aggregate level that we knew before. So when you try to say, this particular implementation or this feature or this function or this product, had an impact in this way, sometimes that's difficult because you're doing a lot of change. You're changing, a lot of things related to the workflow. The markets are changing at exactly the same time. So it's ROI from a pure business perspective is often hard to calculate. The other thing, from just a clinical ROI perspective, I mean, I think, certainly, yet again, a lot of things, may not be able to really be defended, but intuitive make a lot of sense in terms of if you have access to information, you're going to make better decisions. And I think, one thing particularly related to health information exchange is I think we're going to see a time when it's going to be an expectation that you reach out and get information that's available beyond the four walls that you're used to, residing in. And that's very different. And in fact, there's already been litigation, interestingly enough, around cases saying that this information was available to you and you didn't look. And so I think it's going to be interesting as physicians, not only in ambulatory practice settings, but hospitals, emergency rooms, urgent care departments, etc., go from basically always being able to say most times that they had a somewhat incomplete picture of the world, moving to a situation where they're expected to have a complete sort of picture of that patient, regardless of where that patient had care. And the other aspect of that is a lot of the productivity and workflow today is dependent upon the fact that they only could learn so much in a period of time. And if you think about that in an ambulatory practice, you think about that in an emergency department, well, what if the ER doc now has to become familiar with the entire medical history of a patient, where before it was like, well, I only could know what they told me. And
What's right here?
What's in front of me. And so, that 6-minute encounter, I can digest that much, but maybe I can't digest someone who, medical history, who's 85 years old and now has got, literally, an incredible amount of information out there in an exchange environment that now I'm supposed to be responsible for. So I think it brings up a lot of interesting things that we're going to have to deal with in the future. It's not a bad thing that you have access to that information, but I think when you start to look at things like how do you measure the improvement of things pre and post implementation, it is much more multifactorial than what people realize.
Right. And we're going to get into a lot more of some legal implications in a minute, but you bring up a really good point. So it'd be interesting to hear from all the panelists. Out of the 24, 25 parameters out of meaningful use, what's the first best step on the health information exchange? Is it e-prescribing? Is it the full EMR? Or is it alert status that the patient sitting in front of you has an allergy and has also been into 6 ERs in the last 24 hours? Which one of those do you think is the first step?
If I might, just to a point to the ROI question you asked a moment ago, it's not going to be ROI, but it's going to be more cost avoidance that we can recognize with the HIEs. We've documented a number of cases where just having the knowledge of the patient's history has avoided the cost of admitting the patient to the hospital, and patient satisfaction as well. The fact that the patient did not have to go through the processes that they might have experienced had they been admitted to the hospital for additional tests, had they had a procedure done that caused implications that the physician became aware of prior to the procedure. And those are the things that we really see as not ROI, but just the cost avoidance. And on to the meaningful use, it's been our experience that having that knowledge, obviously e-prescribing is so important, but having the knowledge of what medications have already been prescribed, what procedures have already been done, and just the general patient history for the patient has been that meaningful use for the physician. So they do have the information to make that critical decision at the point of care. And we've documented that a number of times.
You know, I think from at least from a stage one perspective, the good news is that as far as the required measures for meaningful use, the good news for most probably for most vendors, and also I would imagine for most providers as well, is that a lot of the technologies and features that are required, many of them have been around for a long time, or at least a long time in terms of HIT circles. So, you know, you mentioned things like drug utilization review and alerts for drug-drug interaction or drug allergy interaction. You know, those services have been available for a good period of time, embedded into most e-prescribing applications. So, you know, I think if you want to do a crawl, walk, run type of approach, you know, certainly moving towards an e-prescribing type of application, there's a certain level of maturity, I think, in the marketplace with different vendors that provide those types of services. You know, where we see the greatest benefit overall, I think, for what meaningful use is doing, and I'd really like to get Jerry's opinion on this. But anything that can drive semantic interoperability, so from a standards and a lexicon and terminology standpoint, anything that can drive us as an industry closer to semantic interoperability between systems is really got to be probably the most critical component in my mind of what meaningful use hopefully can deliver for us. Because once we have that ability for us to be able to exchange information and understand the context in which we're understanding that information, the innovation cycle is going to explode with different, you know, what we've seen in consumerism and what we've seen in other industries. I think we're going to see the same thing here. But we've got to get to a point where, you know, I think Miriam Paramore said yesterday in one of the panels, you've seen one HL7 message, you've seen one HL7 message, right? Yeah. Which was great. So, but if we can as an industry continue to move towards semantic interoperability, and meaningful use can help drive that, it's going to be a fantastic thing.
Well, do you see it as being more meaningful use or more, actually I think it's more of the HIE side that drives the semantic interoperability, because Kim and I were talking out in the hallway, male, female, we've seen 14 different versions of male, female, right. And there should be 2. And so obviously we've got to code that. So is it really meaningful use that'll drive us to that, or is it the HIE where we have to start exchanging information? Because you could have an electronic medical record and have your own definitions and live in a pretty happy world.
If I can,
sure.
You know, I think when we look at the what was the QDS, the quality data set, and we look at the NIST requirements for meaningful use, there is a prescribed set of terminologies. And now granted, for problems it can be SNOMED CT problems, or it can be ICD-9 or ICD-10, so yeah, there is going to be some type of variability. I think at least helping us, if the exchanges are going to be taking information in from the EHRs and providing information out to the EHRs, then getting those EHRs to where, at least from an information exchange standpoint, we know that we can expect in a problem, as for a problem, we can expect A, B, or C. Right. That's a heck of a lot more helpful than A, B, C, D, E, F, and G for some representation of a certain data point.
Or one of the 14,000 new ICD-10 codes. So.
Right.
Yeah, I'd like to speak to how we use meaningful use and how I feel it's going to be impacting HIE's adoption. When we looked at the different stages of meaningful use, you know, stage 1 required in the CPOE arena, the physician order entry side, 30% of our orders to be electronically entered. So when we look at that across our enterprise, we realize that if we implemented all that in the ED, starting out with our emergency department, then we can hit stage 1. Now, stage 2, going up to 60%, presents some more challenges for us. But in trying to hit that by July 1st, that was our approach. So we just started full force into implementing CPOE in the ED throughout every ED, 90% adoption for our physicians in the ED. Not without pain, I might add, but we were very successful in a quick time frame to meet that. Now, how that plays into the HIE is because within Middle Tennessee, we are starting out in the emergency departments. Our 4-system coalition that we're starting out with, our health exchange, is going to be starting out with the ED and looking at the records in the emergency department. So our physicians that are currently working the ED are already getting prepared just through doing CPOE in the ED to start looking at the clinical system. And I think that's where the whole meaningful use has really positioned us well, because it's forcing them to look at the systems and go to the system for the quality data and for the information. So I think it's been a great tie-in with preparing us for the HIE here in Middle Tennessee.